Yeah, so we'll kind of just get right into it. Yes, not being a doctor, I'm very specifically going to avoid, I'm not going to go into the intricacies of what sleep apnea is or talk about statistics, but being a nurse, what I can talk about is the process. So this is really the same information I would share to my patients, teaching them about what the process is to get tested, right, and to start CPAP or whatever that journey might look for them, okay? So, and there'll be a little bit of touch of kind of how it relates to acromegaly, but I'll probably ask you guys questions and be kind of interactive, and I want to leave lots of time at the end for questions, okay? So yes, thank you for giving me this chance to share. Anytime somebody says, oh, you want a microphone? I'm like, yes, I'm weird like that. It's probably theater and improv background, but when Deanna was insisting that I do it, it wasn't very difficult actually to get me to do this. But yes, like I said, the focus of this presentation is really just to say, okay, this is what is involved just to get started into this. Whether you have acromegaly or you think you have sleeping issues or your husband or your wife or your partner is saying, yeah, you stop breathing when you sleep. And you're like, no, you should probably get tested. And how do you even do that, okay? We'll make the connections to acromegaly, but I'll let us kind of get there ourselves, okay? A little bit more about myself. Okay, so I don't actually work in the sleep apnea industry anymore, because apparently after 2 years I just get bored and go somewhere else. So I was working in CPAP when I accepted to do this. Now I'm actually working as a manager in a nonprofit. I'm very passionate about patient education as well. So on the side, I'm also developing a website to help teach healthcare literacy. Because a big theme that's kind of happened and heard of everybody speaking is those initial steps in getting all the stress and the difficulty of just what do I do next, right? Is a huge piece that's usually missing for a patient because they just don't know where to start. And most of that's focused on what my background is actually in home care. That's where I've spent most of my nursing in and consulted lots of patients on how to get started with that. But that will be in the future. So how the CPAP industry works, it's fairly prevalent, and it's largely underdiagnosed. So I'm sure everybody has seen CPAP clinics just pop up everywhere, right? Or themselves have sleep apnea. Of a show of hands, who knows somebody who has a CPAP machine? Okay, yeah, okay. And you may have it yourself, right? So, and I was talking to the ladies that I'm sitting with, we're talking about just how difficult awareness is for something that's very prevalent. Even the awareness piece of sleep apnea and CPAP and what's all involved is extremely low, right? So I can't imagine for something like acromegaly or anything else that's a little bit more rare, what the awareness piece and how difficult that is, okay? So we'll keep going and we'll get into it. So what are we doing? So I'll just touch on what is sleep apnea, just kind of just go over very minimally. I'm going to spend most of the time on how to get tested. Okay, so if there's those of you that are thinking about it or you're like, I'm tired, I want to talk to my doctor about it, kind of what that process looks like. And we will spend a little bit of time talking about CPAP, but I'm not going to dive too much into that. If you have questions, please ask after. And some other treatments I'll chat about. Okay. So first up, what is sleep apnea? So I always tell a patient, okay, break down the words. Okay. So apnea, okay, A means nothing. No, there isn't anything. Apnea means breath or air. So literally tell patients an apnea means there's no air. Okay. And more specifically, we call it OSA, and they're like, what are you talking about? It's obstructive sleep apnea. So typically it's based on an actual obstruction while you're sleeping that causes no air to get through. Okay. So spend time here. So different types of apneas. We have the two first and second obstructive apneas and a hypopnea are both linked to actual obstructive sleep apnea. Okay, the other one we won't dive into much, but I'll talk about it after. Okay, So if I was to describe it and show somebody, if you're laying on your back and you see your tongue and how it is while you're sleeping, typically people, it's like your muscles relax more. Some people have larger tongues, okay? And it's really dealing with gravity, and that's actually falling back and creating an obstruction, okay? That's the very baseline, typical way we see it present, okay? But really, it can be any host of things for anybody that's causing a blockage in the back of their throat. They could have large adenoid tissue. They could have extra large tongue. So if somebody has an extra large tongue, how could that be linked to acromegaly? Anybody? Okay. Yeah. It wasn't a hypothetical, but you get it. So an obstructive apnea, this is a full, complete blockage. Okay, so how this is present is when somebody's actually sleeping, and you might have a partner that does this, and you hear this, and it sounds like they're dying, right? Or if you hear recordings of this, it's very scary to witness. Usually the person that's actually going through it might not even wake up or be aware that they're doing it, but they're going to be breathing, right? Because an apnea is actually counted if it's 10 seconds or longer. Okay? And people get really remarked by that, just like, how many times is that happening? And it's like, well, you're very severe, so a lot. So a hypopnea, this one, so hypo just means low, so it just means low air. So it's not a full, complete blockage, okay? A little bit of air is getting through, and that's usually when we hear snoring, because there's turbulent air and that sort of stuff. But if we're testing also their oxygen levels and we see that dip, okay, then they can actually count that it's also a hypopnea. Okay? I'll get into hypopneas a bit more when we talk about the different tests that you do and how they can count it, but we'll stay there for now. Central apneas, I'm not going to get too much into the specifics, but it works completely different. They call it a central apnea because it's connected to your central nervous system. Okay? So it more has to do with the disconnect from your heart telling you that you need to initiate a breath, right? So if we were testing somebody's breath, we would just see them not have an obstruction, but just not breathe. Sounds fun, right? But also if somebody has acromegaly and there's heart issues as well, that might be something that's developed or would have to look at. But I'm going to stop there because beyond obstructive sleep apnea, then it starts to get very complicated after that. So, how to actually get tested. So first off, and everybody always says this, just talk to your doctor, and it's true for this, talk to your doctor, okay? Go talk to them, okay? Say, I'm tired. Okay, a good doctor will say, okay, let's do an actual screening and ask you these questions, okay? So they may use, you don't see it as much anymore, but we'll actually take a pause and go through these screenings, but you'll see a stop bang. And it's 8 questions that kind of sees how likely you are to have sleep apnea. And then we'll also look at a Mallampati score. Okay, I'll get you to do it, so that'll be fun. And then once you go through screening, you actually do a sleep apnea test, but we'll get there. Okay. So let's take a pause for a sec. I know it's a huge faux pas when you do a talk, but if you want to actually do this test right now, take your phone out. Or you can just read through these and jot it down, okay? If you look up and you put in stopbang.ca, and I'll actually pull my phone out because I did open it here. So if you go to stopbang.ca, and then it should come up and you click see more, it'll go to the actual Stop Bang questionnaire. The reason if you really want to do this, you would go on here because then you can actually calculate your BMI. Okay, because that's an important piece. Okay? Or you can jot these down or just mentally take note and be like, oh yes, I need to go talk to my doctor. Okay? So first question is snoring. Do you snore loud enough to be heard through closed doors? Okay. As we've all kind of seen where it's like people will ask, like, oh, sleep apnea is such a big thing nowadays. But as I would always joke, it's like everybody has a grandpa that you could hear sawing logs in the other room, right? So it's been around. T, tired. Do you often feel tired, fatigued, sleepy during the daytime? Okay. Just yes or no. O, observed. Any witness apneas or gasping and choking while asleep? Okay. Lots of people who don't have a sleep partner aren't able to answer this, okay? Because you always have patients say, no, there's no way I have sleep apnea because I don't wake up choking, okay? That is a big misconception, okay? You can do all of this, not have anybody witnessing it, and you have sleep apnea. You're not necessarily waking up choking, but you're still having very severe apneas, okay? P is pressure, okay? Because if somebody has sleep apnea, it's going to affect their blood pressure. So do you have, or are you being treated for high blood pressure? B, body mass index, okay? So we want to look for a number that's lower than 35. If it's above that, then it would be a yes. A is your age. You're older than 50 because they have higher risk. Neck circumference. This is dependent on male or female, so just kind of put 16 inches or above. Really for males, it's 17 and above. And then G, male or female, because males are more common to have sleep apnea, okay? So if you did that on there, then you get a score, right? Or if you noted these down, and then you can see in the corner, okay, if 0 to 2 of the questions did, it's listed a low risk. Okay, so maybe have a chat with your doctor. It might be something else. Still worth talking about your sleep, but they might look at other things. Intermediate risk if it's 3 or 4 questions, and then high risk if it's 5 to 8, right? So a doctor will use this screening tool to go, okay, we need to fill out a form. Okay. So next one. This next one, you don't actually have to do this, but if you want to, we'll have fun. So this is the Mallampati score. So if you look to your friend next to you and you go like this, okay, then you can actually score each other on what this looks like. So the Mallampati score was actually developed, I believe, for intubation during surgical interventions. So when somebody's put under general anesthesia, they need to know how much space they're working with if something happens and they need to put a tube in. But then it's also been widely used to see what higher risk somebody has for developing or having sleep apnea. Because if the tongue is covering large areas of the mouth, then we can kind of safely assume that there might be sleep apnea at play, okay? So yes, the class 1, you can see lots of space. You can see the uvula hanging, the hard and soft palate. Okay, class 2, you start to not see quite as much. The uvula is partially taken away. Class 3, you don't really see the hard palate anymore, okay, but you can still see the soft palate. And then class 4 is like you see nothing, okay? Yeah, so keep going. So these are the 2 different tests, okay? The PSG, that's the very complex hospital one that we almost try to avoid. It's very expensive. It is covered by BC Medical, and I'm sure in other provinces as well. But the one above it, the home sleep apnea test, was developed to kind of offload people going in for a hospital sleep test to do a less expensive one that they could do at home for less complex patients, okay? So working in CPAP clinics, most of the time people will be like, oh, do you have a bed in the back? Most CPAP clinics only do home sleep apnea tests, and they're accredited just for that. The closer you get to like Vancouver and bigger cities, you'll actually have clinics that do polysomnographies, or you'll have hospitals that run them, and that's not my area of expertise, but I'll just touch on it a bit. But home sleep apnea tests, so you go to your doctor, you get screened, okay? They are going to send this out to an accredited facility, and how do they do that? They're going to fill out Form A. So this is a requisition for a home sleep apnea test. And it's very specific. It has data that might exclude you from it, and if you are excluded, then they would move to the Form B, so somebody can actually talk to a sleep physician and see if a polysomnography is the best course. So home sleep apnea test, they might go through the screening like we talked about. They ask those questions. They fill and sign this out. This gets faxed to a accredited facility. Maybe there's one that they know of, or there's just a list that you can actually click and a link that tells you all the places that are accredited to do HSATs. And then it comes across like my table, and then we take that and call the people in to do a home sleep apnea test. Okay. I'll jump into polysomnography, but we'll get there. Okay, so home sleep apnea test, so an HSAT. Okay, it's also called a level 3 test. I always joke in the medical field, everything has at least 3 names, okay, but don't get me started on medications, which have like 19. So home sleep apnea test, HSAT, level 3 test, all the same thing. Okay. So it tests for 3 factors. It tests for airflow, okay, with the nasal cannula, as you can see. Second, with the belt that actually goes just under the sternum, and they wear that as an effort sensor. Okay. So when you actually, that breathing effort, it's calculating that as well. And then 3, you have the oxygen and heart rate. So I guess really 4 categories, but you're wearing a finger probe that calculates your oxygen and your heart rate. Okay. So this is quite simply, you get it scheduled, you go through all the steps that we already talked about. You come and you pick it up at the clinic, okay? You take it home. Okay? You watch a little 4-minute video of how to use it, and you perform the test. And the very next day, you bring it back. Okay? Depending on how the clinic operates, not a lot of clinics actually have doctors within them, so it'll be sent out. An HSAT gets scored, so we send it out to a polysomnography tech who needs to actually score these. Then we get that back, and then we take that information and send it to our consulting doctors. Then they actually create a diagnosis and report that we can send then to their doctor to receive a prescription or not. Okay? But any one of these things, we don't really initiate these kind of conversations. And there was recent policy changes where it's like, you get the test and we can't talk to you until you have a prescription after. Because it was starting to get to the point where people were having some misinformation and they wanted to protect that. So, polysomnography test, also called a level 1 or a PSG, or I like to call it a many sleep test, okay? Because that's literally what it means. Because poly means many, som means sleep, and graph is essentially test. So it's a many sleep test, and that's literally what it is, okay? Because there are 7 to 9 factors. You have 2 chest and an abdomen belt. You have about, I believe it's 9 diodes on your head. You have a nasal cannula, you have a finger probe. You also have accelerometers on your wrist and your ankle. If you're kicking or thrashing and stuff, they're calculating that. So this is calculating much, much more than just sleep apnea, okay? So the HSAT, we can't even call a sleep test because it is not a sleep test. It is a sleep apnea test. A polysomnography is an actual sleep test. Okay. So somebody would actually go into a hospital. They would, it depends on how the hospital runs them. I know Abbotsford General, there's 5 beds, so there's 1 or 2 polysomnography techs that actually monitor them, watch you sleep. They strap you up with all of these. You sleep and get tested overnight. And the running joke in sleep health is we'll duct tape this to your face and see how your sleep goes, right? So it's a difficult process to kind of get this going, to really make this work, but those things are available. So yes, this is the hospital overnight. There are some clinics that run them as well, okay, and you're monitored by a sleep tech, okay? And sleep issues is a very broad umbrella, okay? And obstructive sleep apnea is just a small part of this. Okay? I'm not gonna get into all the other ones, but somebody, they might not have sleep apnea come back positive, but that doesn't mean that they don't have some sort of other condition, okay? So CPAP, and the reason I focus on CPAP is because CPAP clinics, that's all we really do. And it is still considered like the golden rule and the golden treatment for sleep apnea. There are other treatments, and I'll briefly talk about those afterwards. But the primary treatment of obstructive sleep apnea is a CPAP machine. So it means continuous positive airway pressure. Okay? And we've all seen them, and people always ask, am I gonna look like Darth Vader? It's like, no, it used to be that way. What they're really asking, am I gonna wear a big full face mask? And there's not, most masks are nasal masks these days, okay? So you have generally 3 pieces. You have the CPAP machine, which we call the blower, okay? We have the accessories, which is a heated tube and a heated water tank. And then we have the mask. So somebody is wearing this mask, pressure is being provided, not to force air into the lungs, but really just to keep the airway open. Okay. So CPAP machine might look something like that. Okay, there's some that are very common. I won't talk about like specific companies and that kind of thing. The mask, I don't like have any on hand or that kind of thing, but please ask questions about other masks, or if you're actually actively using, if you have lots of questions, please do ask. But the masks, they're much less intimidating than people think, especially now, because nasal and nasal pillow masks, which are an option, which just create a seal at the nostril, are actually have been shown to be better for sleep apnea as opposed to a full face mask. When CPAP machines kind of first started, I believe, like I know the guy who developed it was a doctor in Australia, and I heard that they used to have full face masks that were made out of fiberglass that they would glue to your face. Okay? And so things have come a long way. The reason a nasal mask works better, if we can help it, is because the pressures are going to be going through the nasal cavity and almost like taking a right angle turn to open the airway. So we usually don't have to supply as much pressure to keep that airway open. As a last resort, if we absolutely need to, we'll do a full face mask, but what we find is it's a large amount of pressure, also pushing the tongue back and creating another issue where we have to supply more pressure, and it's more complicated. There's more surface area, there's other things going on, there's more complications, right? So 9 times out of 10, it always starts somebody on a nasal mask, even just to trial it out. And then you have the water tank, because we know rushing air is going to be very drying. Most people, if they were just going to do on straight air, they would have nosebleeds and other things. Some people, it's not for the machine at all. It is for the patient. It is for comfort, but it's heated and humidified air. Okay? But you can run them completely dry and cool, and some people prefer that. But most, we always would start with the heat and humidity. People ask about that. It's just like, why is that the case? In our anatomy, it's our nasal cavity heats and humidifies our air. So blowing a bunch of unnatural air, we want to do that as well. And then we have patients come in. They do a trial for CPAP. Okay, it goes horribly. They have worse sleep. It's not working for them. As I always tell people, CPAP always works. It's going to force that airway open, right? It's going to work. It's whether you tolerate it or not. Okay? If somebody can't tolerate it, that's fair. We will try everything that we can to mitigate the discomfort and try to make it work and look for avenues for that. But there are people who just cannot tolerate CPAP. Okay? So then there's other options. Okay? So if you hit a wall, and you're working with like your CPAP clinician and it's just not going anywhere, you do the trial and it's just, you hate the thing, okay? You speak to your doctor about next steps, like if this doesn't work, what do I do? Okay. Typically get referred to a specialist, and that's what this arrow is for. I usually only tell people it's one of 2 ways, okay? It's a respirologist or an ENT. Okay, but dentists, also there's a mouth guard, which I'll talk about in a sec. That can be alternative treatment. So, like I said, sleep disorders, so many of them. Obstructive sleep apnea is just a small piece. Okay, if we try to jump the gun and go to a polysomnography and look for some rare disease, doctors aren't going to do that. They're going to follow the hierarchy of like, we need to check this first. So what sleep apnea ends up being for the sleep health world is a precursor to everything else. Okay? You'll have patients come into the office all the time and be like, I have no idea why my doctor sent me here. And they'll ask them questions and be like, oh yeah, I have this surgery for this thing and I have to go under. I'm like, that's why, right? Because if somebody's going under surgery, the doctor needs to do their due diligence to make sure that if they have sleep apnea, that they're being treated while they're going under surgery. So there's lots of reasons why, or they're usually not going to be sent to this, that, and the other to investigate these other reasons. They'll always look at CPAP and sleep apnea first. But if it's not working, and we would work with respirologists and ENT all the time, so they get referred to a respirologist to look at doing polysomnography possibly, or looking at a more complex machine, which I won't get into, which is BiPAP machines, because as soon as you get into BiPAP machines, there's like 7 to 9 different types, and they get more and more complicated, and that's not my expertise. But if they need actual surgical interventions, right, for the back of the throat, the tongue, removing the uvula, or nasal cavity, things that need to be surgically done, then you would actually go to an ears, nose, throat doctor. But I know where our clinic was in Chilliwack, there's one ENT, and the waiting list is a year. Respirologist is usually 3 to 6 months. Getting a polysomnography is usually a 6-month wait as well. So we always try to make CPAP work for people. And even these specialists will always be like, why are you here? Did you do CPAP? Right? They'll always encourage you back. Right? So would be very upfront with patients about that. It's just like, you really need to try and make this work, because even if you go to the next step, they might try to kick you back, right? Because they should, because you really should try to make CPAP work, because it is the best option. Okay. Dentist, so another one, it's called a mandibular advancement device. And so you go into a dentist, special dentist that actually do these. They would make a model, they would create this device which would actually move the bottom of your jaw slightly forward to help create a bit more space, so you can do that. Typically it only helps with milder patients, but it is an option there. But the cost is upfront and is quite expensive, so yeah. Other than that, that is about it. And just want to open it up to questions. If there's anybody who's on CPAP wants to share anything, that's it.
Anybody have questions?
One question for you.
Yeah. Get the mic. Mike.
I'm asking this for everybody. It's something that Tracy found out, and we actually had other friends of ours that had CPAP machines, and they were not aware of this. But how frequently should you be cleaning the hoses?
So general recommendations. So the hose and the tank, generally once a week, right? And that's like a full clean with just soap and water. Usually tell people like Dawn soap is a good option. And you rinse it out really well and let them air dry. Some publications and some things that you would look at, they actually say do the tank after every use, right? But then, so those are once a week, typically. But the actual mask, the part that touches your face, is daily. Yeah, what we call the cushion, you have to do it every day. But yes, the upkeep is a lot. That's why you need somebody supporting you with CPAP.
Can you talk a little bit about funding for these machines?
Yeah. Very long. So it is typically just private funding. So it would be extended health benefits. Most extended health benefits are typically pretty good. It's anywhere from like 80 to 100% of coverage, and there's caveats to that, but plan dependent, very plan dependent. The only government help would be for those on income assistance and through the Ministry of Social Development and Poverty Reduction, or First Nations Health Authority, right? And then you go through those, but then the hoops to actually get somebody funded for those is much larger, like it would be for anything. But yes, it's all private. There's no government funding. I know that's not true in Ontario. There is partial funding, I believe, in Ontario. I don't know if anybody nod for that, but yeah.
Yeah, just a question on the maintenance for the machine. Like, how often does the machine need to be changed? Does you have to change it, like if it stops working, or is it one of those where it's like, I had mine for 2 years, and the people I got it from called me and told me to change it. I'm like, it works fine. You seem like you're scamming me, and so I just hung up on them. But I wasn't sure how frequently that actually should happen. So.
Yeah. Most machines, the motor life is 5 years. Okay. And so extended health benefits would also typically follow that as well, right? They would do a full replacement every 5 years. Unless you changed insurance and you never claimed one, then you could, and maybe that's why they say, oh, you change your insurance, how about getting a new one? I don't know, I'm not gonna speak to that. But, so as long as there's no actual like full-on cleaning that you really do with your machine, but there is an air intake filter that you absolutely have to change every 3-ish months. And we tell people inspect them once a month, flick out extra dust, and make sure that's changing, because that will actually keep the motor life. They're under warranty for 3 years for most companies. And if you hadn't changed the actual thing, they'll recognize that and they won't replace it, right? But it's really a machine is a 5-year. Yeah, it's 5-year, you need a new one.
My daughter comes, sleeps over, and I'm snoring a lot. I went to sleep clinic before pandemic, and they told me I don't need a CPAP machine. And second time I had over the phone during pandemic, and they still told me I don't need a CPAP machine. So, but I'm still snoring. So what can I do about it?
So I can only give general information. First answer I always give is talk to your doctor. Generalized information of just, did they tell you why? Okay. So there may be reasons, but if you're still snoring and you want to investigate it further, you just have a conversation with your doctor again and just start it again. There could be a whole host of reasons why they would say that. Snoring doesn't necessarily mean sleep apnea. That's kind of the best answer for that. Yeah.
So just on the note of the CPAP, sleep apnea machine, I went in and had a test probably 6 years ago, and the guy recommended, yes, I do need it. And that was on Broadway, and he has multiple stores throughout GVRD. And I said, how much? He says, well, it's $2,200. He says, do you have health coverage? I said, no, I do not, self-employed. He's like, well, I can give you a good deal, then I can get it to you for $1,600. And I took it home for a week to test and stuff, see if I was comfortable. I didn't like the nose clamp. My buddy swears by it. He was a chronic snorer, and he has the face mask. But here's the thing. I looked at the model number because I had the week of testing it. I just went online. I could have bought it for guess what price? $475.
Yeah.
But you still need to have a prescription to get it.
Yes, you do. Yeah.
Yes, you do. But keep acknowledging the fact that the price markups are horrendous. And
I can explain that as well. And I don't work for CPAP industry, so you know, I have no vested interest in it. Yes, the reason that is, so CPAP clinics are typically not operated by doctors. You'll have respiratory therapists or nurses that are operating it. In Canada, like typically we can't charge for our time, right? So how it's kind of done through extended health benefits, and it's kind of like a mutual understanding with extended health benefits, is that our prices would typically be twice as much, if not more, because you buy and you replace and you do all of the upkeep and everything as a patient, but it is very much like sales, and because it's privately funded and industry like that. So the ballooned cost is paying for the clinician and whoever else's time. So that's how it is, because if somebody comes in and purchases a machine, what you're also paying for is the upkeep, the monitoring over the first month in the actual trial and doing all of that, changing out masks. You still have to purchase masks further on when you have to replace them, but you're not being charged when you actually come and visit and charge for service, right? So it's just how they kind of navigate it to kind of soften it, right? But when people will come and be like, I can just buy them online, what I would say is like, how long you've been on CPAP? And they'd be like, a year. And And I'd be like, probably still wait, right? Have somebody follow with you so you're actually doing things properly. I would say if you've been on a CPAP machine for 10 years, go for it, right? Because you probably understand the world. You've been doing it for a long time. You're a better expert than people that you might be talking to even sometimes. So then you have that full ability to go with it, make sure you have a prescription, get those necessary things, and buy and purchase the things that work for you. But kind of under the 5 years and under that time, it's not typically recommended, but also empowering people to make their own decisions I'm very much for. So I would tell them this is a reputable place that you can actually buy them, and this is their process. I had no fear in doing that. I would just tell people this is how you buy online if you want to go that route. So, yeah.
Yeah, I just failed the stomp test. My neighbor just told me she couldn't. But what if you're a nasal breather and they put that thing in your nose? Is that, it doesn't matter?
So if you're a nasal breather, it's actually a good thing. Because the difficult thing with putting people on a nasal is somebody has sleep apnea, they're very likely to be a mouth breather, or at least when they sleep. Because when your body is starved for air, what are you going to do? You're going to breathe like this. So, but when you put pressure here and your mouth is open, it feels like you're on a vacuum, right? Because all that pressure and air is escaping here. So then you have to be very conscious to keep your mouth closed. I tell patients, okay, now shut your mouth. So keep your mouth closed and breathe in and out of your nose very calmly. So if somebody's naturally a nose breather, that will benefit them, right? Because then they're not having air escaping and getting dryness happening through their mouth and that sort of thing. They're actually able to keep their lips closed and breathe in and out through their nose. And you have to be less aggressive with pressures, and it's usually much less complications. Yeah.
So what would you recommend for our nose and for our mouth to stop the dryness while we're using the machines?
Yeah, talk to the person that's supporting you, because most discomfort issues can be adjusted. The way machines work now, it's all remote, so any settings that need to be adjusted, except for, save for a few, can actually be adjusted remotely. So we just go online, your profile is there, your machine's added there, and we would change and tweak the actual heat and humidity to find the right balance. Somebody can self-change those, they can learn how to go into it, and we always just say, just be very incremental of how you increase the humidity level. So it's like, turn it up one, see how it goes. Okay, it's still dry, turn it up another, see how it goes. If you turn it up again and you have a bunch of like condensation or wetness, turn it back down one to find that sweet spot. Also with the heated tube, the more warm that it's going to be, the more moisture is going to be carried in with the air, so you can also tweak that to make fine adjustments. But usually if there's like a real dryness issue, we're going to be looking at mask leak. We're going to be looking at are the settings actually adjusted properly, and kind of just reviewing that stuff for you. So that's why you have somebody supporting you in it, because it's like it could be going good for a while and then it's not, and you go in and talk to your clinician and get things adjusted.
Oh, quick question. What's the rate of people stopping their in Canada? There's, you know, where you somebody says, oh, you have mild sleep apnea, you try the machine, and you go, forget it, I'm not sleeping with this thing, and they don't do it anymore.
Yeah, probably not the best to speak to numbers, and I like intentionally avoid it, but I know it's like in the millions of people that have it, and it's generally around 70% are undiagnosed as well.
Yeah.
Right. So yeah,
that's and just leads to the other question is, do you think there is a tendency to overprescribe for people that have sleep apnea? Because we've read that, you know, as you go through the literature of sleep apnea and where.
So this comes with the difficulty of private funding, especially in Canada, because people aren't used to that, right? And then you get into the sales dynamic of, like, are we doing it to sell a machine, or are we doing it to actually treat somebody, right? But then you have medical professionals that are doing it, and we're tasked with making sales, but we're always like, no, we're treating patients, right? So there's always that weird balance. So then you do get some, okay, very much, I want to say some, there's lots of good CPAP clinics, there's lots of good things, and especially how things were done probably 5-10 years ago, we're very much operated on the fact of like, you need to get a machine. Okay, you got new insurance, get a new machine. Okay, the way it operated like that, it was very sales focused. And I know for myself, I was very person-centered focus. So being overdiagnosed, I wouldn't necessarily that, because there is data to say that it is underdiagnosed, but what my thought would be is the wrong information is told to the wrong people, right? Rather than the right information to the right people. The people who actually need it are taught properly. That wasn't always happening. It's like somebody who maybe could benefit from it was really told they need it, rather than somebody who really needs it is told the right information. I don't know if that answers it. But yeah.
One quick follow-up. I know, it's funny. I'm sitting down now because Deanna wants to get the mic. So my buddy was married for God knows how many years now, at least 35, and as soon as he got his machine, quiet has descended in the bedroom and the wife can sleep and not be woken up. If you're on a limited budget and you have no health care coverage for that machine, would you recommend killing two birds with one stone and getting the portable one so you have the ability to take it to Vegas and use it in the home, or would you use the full-size one?
I would always tell people use the full-size one because they're not that big these days. Also, maybe 5-10 years ago, you would try to take them on a plane and they'd be like, oh my gosh, what's that? These days, you take a CPAP machine on the plane, they're like, yeah, go ahead. And they're all graded for air travel as well. And there's other issues with the travel machines. They're loud. They don't technically have humidity, so you have to be used to that. There's other things that come with it. They're very expensive as well. You wouldn't necessarily be saving money, so I'd always be like, I know it seems like a lot, but pack it up in its actual thing and take it with you. If you look at the sticker on the bottom, they'll have a little airplane on it, so they're actually graded for that. And I learned a bit more about that because the guy I started working with used to be a flight attendant, and he's like, you can even operate it on the plane, they just don't want you to be using any water. It's in addition, because it's a medical device. It's like bringing a cat for emotional support.
Okay, thank you very much. That was great information.
Thank you.